What I'd like to do is talk to you a little about cultural competency. As we know, the state of Connecticut now requires all physicians to do CME work in cultural competency. It's considered one of the most important core skills and abilities that doctors have. Can I just see a show of hands? How many people here are physicians who are here for CME purposes? Okay, great. So this will help many of us with our CME process. But let's think about what cultural competency means. And I go back to one of my first exposures to the area of cultural competence. And it was a lecture where people talked about how, there are racial and cultural experiences that shape healthcare. I said, well, that sounds fantastic. And the person said, well, yeah, I'll give you a good example. They said Hispanics absolutely don't tolerate pain well, and they tend to over-report pain. Okay, I'm thinking, who does tolerate pain well? Okay, is there another group that tolerates pain well? And then the second point was, and black men don't like to get prostate exams. I'm thinking, well, do white men like to get prostate exams? I haven't found too many men who do like to get prostate exams. And what became clear to me early on was that in our effort to try to make us more aware of cultural differences, we basically had taken cultural competency and made it stereotype training. And we went through the stereotypes. And of course, there's stereotypes that fit some circumstances, but they are just that. They are stereotypes. And one of the great advances in the past 5 to 7 years has been an understanding that it's not about learning about, and when we were at the Schwartz Center, we sponsored so many conferences on cultural competency. We'd have someone come in from Laos, because in Boston we had a big Laotian community, and tell us basically about all the stereotypes of Laotians. And they said, the next time you see somebody from Laos, make sure you don't talk about depression, because Laotians don't like to talk about depression. And you realize that those kinds of stereotypes, if anything, make you less able to connect to patients. And what the process has evolved to now is an understanding that it's really about connection. It's about making that connection with a patient, meeting that patient on their level. And what good cultural competency training teaches you is to pause for a moment and say, the person on the other side of this discussion may not bring the same social, cultural background to the table that I bring to the table. And making us more aware of each other's backgrounds, belief systems, will be critical. And the best cultural competency training I've ever had are courses that teach us to ask, so what does this mean to you? How would you like to hear this information? What does this disease context mean in your given circumstance? I remember back to seeing a patient who was a physician who came to me from Italy, and he was an infectious disease physician, and he had end-stage cancer. His body was absolutely riddled with cancer. And I sat down and I had an interpreter who was with me, and we were about to talk to him about what the cancer, how we would approach the cancer and what the various treatments would be, when the family turned to me and said, Dr. Lynch, you absolutely cannot tell him that he has cancer. I paused for a second. I said, well, he's a physician from Italy. He came specifically to see me. This is a cancer center. And they said, no. He thinks he has a really bad infection, not cancer. And what caused me to pause, I immediately resisted and said, that's ridiculous. We must tell him he has cancer. And they said, but in our culture, that's not the way we do it. And it took me a while to talk with them and reach a place where I felt I was able to talk to him about his cancer and yet not offend the family. What did it take? It took a lot of extra time, because I had to sit down and learn about how cancer was viewed in Sicily. He was from Sicily, actually, in a Sicilian population. And then I had to find a way to be able to tell him, because while his family might not have thought he wanted to know that he had cancer, he desperately wanted to know he had cancer. He wanted to know what he was facing, and he knew, he was a very smart guy. He knew deep inside what he was looking at. So this ability of allowing us to connect to patients is incredibly important. What I want to share with you in the next 20 minutes is a little bit about the Schwartz Center that you heard about, and about how we are working to create opportunities for connection, and how important that connection is. And this transcends more than just healthcare, or more than just a doctor-patient relationship. Connection's what's important if we're going to ever improve our schools. Connection's what's important in our workplaces. We seek to get better workplaces and a more productive workforce. connections and understandings between people are absolutely essential. So because this is a CME talk, as all of you are physicians know, we have to have a disclosure slide, okay? And this is my disclosure. None of these are really relevant to what we're going to be talking about today, but I always think it's important to have it in there. So let me start by telling you about Ken Schwartz. Ken was a gentleman from Boston. He went to Yale College, and when he and I met, we did talk a lot about New Haven. And his brother also went to Yale. So he spent about 4 or 5 years here, played soccer for Yale. And when I met him, he was a 40-year-old dad and husband, diagnosed with lung cancer. And I met him in November of '94. And I was just getting going. It was my 3rd year in practice in November of '94. And I still knew that I was pretty early in the game. And meeting Ken, who was about 6 years older than me at the time, was really a very formative experience for me. We treated him with everything. I put him on clinical trials. We gave him the very best chemotherapy we had back in the 90s. He was a never smoker. He ended up dying of lung cancer in September of 1995. But what he did and what he recognized was that the connection with caregivers made an incredible impact on him and made an incredible difference. And he published a paper called A Patient Story, and that's back when people actually read Sunday newspapers. And it was the Boston Globe had a Sunday magazine, and in this, he basically had the whole issue of the magazine to tell his story. And what he said was that the care he got represented the best the system could offer: compassionate, engaged, and willing and able to spend the necessary time. Now, Ken's profession was a healthcare lawyer, and he represented hospitals, he represented insurance companies, he represented patient groups, all different constituencies. And he was from a medical family. His dad was a physician, his brother was a doctor. And at the time, if you go back to 1994, we were in a really similar place to where we are today, in that we were undergoing a big period of healthcare reform. Many of you have a memory that can go back and remember the word capitation. And capitation and Hillary Clinton's healthcare plan were really the thing that we were all talking about. How would healthcare change? And Ken knew that we needed to fundamentally make changes in healthcare. And I think he'd be delighted to see that we're finally starting that difficult process of making changes and making our healthcare system more accessible throughout our society. But he really worried that the financial pressures that we were facing were going to make doctors spend less time with patients, make doctors feel more hurried, make doctors feel that they were in much more of a world where RVU production, we didn't even have the word RVU production back then, but that RVU production and pressure was going to be the dominant way that they were judged, as opposed to their ability to connect to patients. And interestingly, the Schwartz Center just completed a survey of the state of compassionate care in American healthcare, and doctors actually feel that way now more than ever, that they're more pressured than they've ever been, that they have less time to engage with patients, that that's affecting their ability to provide humanitarian and compassionate care. So, a couple of quotes that come from Ken's story. Despite all the efforts, nothing I did worked. No chemo I gave him shrunk his cancer. No clinical trial made him live longer. He died after about 9 months. But he left us with some important observations. The first is, I've been touched by the smallest gestures, a squeeze of the hand, a gentle touch, a reassuring word. In some ways, these quiet acts of humanity have felt more healing than the high-dose radiation and chemotherapy that hold the hope of a cure. Now, this may seem like an obvious observation, but for us, at least in Massachusetts at the time, at least the people who were working in this was to us an incredibly important observation when it's coming from a patient. He also talked about his worries. In such a cost-conscious world, can any hospital continue to nurture those precious moments of engagement between patient and caregiver that provide hope to the patient and vital support to the healing process? Now, if anything, Ken's worries from 1994 are just as valid today, just as critical today as we face a new revolution in how we organize and deliver care in the United States. So what we did after Ken's death was form something called the Schwartz Center. And Yale has been one of the 3 or 4 centers in the country that have been most closely associated with the Schwartz Center. Yale New Haven Hospital has had Schwartz Center rounds for more than a decade. Yale New Haven Hospital and Yale School of Medicine have also sponsored training in spiritual care, in allowing caregivers who are professional caregivers, doctors, nurses, to train in spirituality and to train in ways of being able to provide important care to patients from a religious standpoint. So the hospitals and the medical school, the hospital and medical school have been very involved in the Schwartz Center. The center was established in 1996, and it's really existed to provide a strong and active voice for promoting and preserving a healthcare system that values empathy and compassion for every patient. And in 2 weeks, we'll be celebrating our 15th anniversary with a large dinner up in Boston to celebrate and to talk about this. So the mission of the Schwartz Center is to support and advance healthcare in which caregivers, patients, and their families relate to one another in a way that provides hope to the patient, support to the caregivers, and sustenance to the healing process. And one of the things that we have done as one of our most important initiatives has been focusing on cultural competence, because we recognize that that is one of the most important missing links in so much of our care. And we've promoted and we have supported a number of programs that have allowed caregivers to work with people to help them become more culturally competent and more in the moment with patients. So what are the kinds of things we're doing? I mentioned the Schwartz Center rounds. I'm going to give you some good examples of what the Schwartz Center rounds are and some of the observations from them. We worked on clinical pastoral education for healthcare professionals. We've established, and that's the clinical CPE program, and I talked about the religious training that Yale has participated in. We developed a Compassionate Caregiver of the Year award for the state of Massachusetts, but that's now being broadened, and many other states are doing this as well. We have a patient dialogues pilot, which is doing extraordinarily well, where we're listening to the patient experience in healthcare. We've been involved in many of the Patient Family Advisory Council movement in many of the hospitals. Yale New Haven has a spectacular Patient Family Advisory Council, and a number of Connecticut hospitals are doing this as well, where we bring in patients and say to them, hey, what's working? What's not working? How can we do better? One of the things I think is important, we've built a spectacular cancer center, cancer hospital. But you know what? If you don't sit and meet with the families and the patients and say, okay, this is beautiful, but what can we do better to make this meet your needs, to be able to make you feel more welcome here, for you to feel more embraced and feel more central to the mission. We've given grants in communication training, cultural competency, and end of life. And I would say that those three themes, communication training, cultural competency, and end of life, have probably been the three things we've spent the most time and effort in. So let me give you a sense of the Schwartz Center rounds. And this room is perfect because this is the room we have Schwartz Center rounds in now. And we had Schwartz Center rounds here about 3 weeks ago. And I'll give you an example of what the rounds are like. But the idea is to provide a forum and a level playing field where caregivers from diverse disciplines can get together and talk about the difficult social and emotional issues that impact us in medicine. And what I mean by this is there's not a place to put this stuff. What do I mean by this stuff? I mean the stuff of taking care of a patient and having it impact you and have it affect you. A chance to talk about what that's like. And you say, well, haven't doctors always had that issue, or haven't nurses always had that issue? Well, doctors particularly, in the old days, my father retired about 15 years ago. He practiced for about 40 years. I know Dr. Borgstrom's dad was a physician as well. Physicians used to support themselves much better than we do today. My dad, I remember being a kid, my dad talking about every day he would have lunch with the same 10 or 15 doctors in the lunchroom. And they would be talking about patients, talking about cases, talking about what their practice was like, supporting each other in that culture. I can't think of ever having lunch with a doctor in the past 10 years. Doctors, in this group, we don't take time for lunch. We don't take an hour to sit there and bond and connect with other doctors.